my name is Nick Boemio. I am a 2017 grad of URI Pharm.D program, and I'm originally from New Jersey, but currently live in Middletown, Connecticut, and work in Farmington, Connecticut.
Oh, excellent. So,
so still New England area.
2017. So what did you do?
Hell of a year.
Hell of a year. So, so what did you do after your graduation? I mean, I know the answer because we worked together.
Yeah. For all you viewers at home. So after graduation, I applied for residency, and I ended up doing my PGY-1 and PGY2 year at VA Connecticut in West Haven, Connecticut. And my PGY2 was a specialization in geriatrics. And then in between my PGY1 and PGY2 year, I also applied to and passed my test to get my board certification in pharmacotherapy specialty. So now I have a couple extra letters after my name, which is always exciting. So I'm trying to go for, the whole alphabet, hopefully by the end of it. But for now, I'm happy with what I got.
Are you missing a couple letters still? Probably like a Z.
Yeah, Z is going to be real tough to get, I think. We'll still have to look into
I don't know any credentials that'll give you a Z. That'd be cool.
Well, I'll have to make one.
Yeah, you'll have to credential yourself. That seems to be how pharmacy's going.
Exactly.
So why did you choose URI for a pharmacy program, being from New Jersey?
So I mean, the appeal of URI specifically was that it was a 0 to 6 program. Not having to reapply after 2 years and take the PCATs was huge. Definitely a major plus just from that standpoint, and just feeling more comfortable in knowing that, if I did well as a student in my first 2 years, that I would be accepted into the graduate program. And I feel like it also just, I didn't know this at the time, but I feel like after the fact, talking to people from other pharmacy schools, I realized that because it's that way, and it's so much less competitive amongst one another to get those seats in year 3 and forward. I feel like you just get to build a lot more friendships. People are more willing to work together, do study groups together, and things of that nature. So it ended up, having a lot of other benefits that I didn't think about at the time of applying. And then, the other thing too is Rhode Island is a gorgeous place. Being from New Jersey, never set foot in the state of Rhode Island except for when I did my tour at URI. So it was a new place. The campus is super nice, and over the course of my time there and since then, it's gotten even nicer with new facilities and things like that. And then, the best part is moving down the line, living near Narragansett. To this day, probably the nicest house I'll ever live in, right by the beach. And I got to live there as a college student. So, living the life, and it was like super cheap too. So you can't beat it. It was awesome. And it was something I won't forget.
For all you viewers, if you want to look up Eastward Drive, that was the place.
That's the place to go. Yeah. Or down by Bonneview is where I live. So hopefully that place still exists. Charlie O's is gone now, but hey. Yeah. Hopefully for you guys at home, there'll be fun places to go to.
They'll still have the Bonneview.
So, some things change, but some things, they stay the same, Chris.
So what was your favorite memory at URI?
Oh man, that's a tough question. I think probably the best part about URI is the people, not only the students, but also the professors. I made lifelong, friendships and mentorships at URI. And to this day, the 4 other guys that I lived with down the line, like, we still keep in touch now. Now we're starting to be in each other's like wedding parties and other things like that. So, you grow up and, but those relationships, always stay the same. And the other thing too is, when I was finishing pharmacy school and applying for residencies, like, a lot of different professors were there, had my back, wrote wrote recommendation letters, gave me advice, talked about different programs that maybe I wasn't looking at initially. So I'm definitely, forever thankful for that. And it got me to where I am now.
Cool. And speaking of where you are now, nice transition.
That's a great transition, Chris. I'm impressed. Thumbs up. So after I finished my PGY2 in geriatrics, I worked briefly per diem at the VA in the inpatient pharmacy until I got my current job now, which is at OptumCare Network of Connecticut and ProHealth Physicians. And my title is Clinical Pharmacy Specialist of Patient Care. My job is extremely unique. I mean, technically it's in the managed care space, but I feel like my job is very, very clinical for something that would probably fall under that categorization. So, I mean, just in terms of some of the roles and responsibilities, I am the only pharmacist currently, and I mean, hopefully we'll expand our pharmacy team as we continue to grow. But right now, I mean, if it's medication related, your boy's doing it. Like there's really no one else to delegate to. So the types of things I do, I run drug information services for the primary care providers if they have any particular questions. We have an opioid tapering service. I help a lot with our policies and procedures, so developing medication use guidelines. Recently, we're working on a nurse-driven protocol for dosing warfarin. I also work on the insurance side of things where we do like quality metrics and star ratings for statins and antihypertensives and diabetes drugs, med adherence, etc. And then I also am part of the case management team. So I work directly with our nurses, our MD, and our social workers to do medication reviews on our highest risk patients. And sometimes that involves, talking to the patients, providing counseling, but most of the time it's just coordinating care with the primary care doctor, specialists, and then also the case management team themselves. And, every day is different, which is kind of awesome. Like I never know what I'm walking into when I get to work. But it's pretty cool. And I feel like I really got to flex a lot of the knowledge and skills that I developed in pharmacy school and residency and really get a chance to apply them and grow as a pharmacist, and hopefully, down the road, get to expand out the team and kind of be in charge and be the manager at some point. So we'll see how things go.
Definitely. So when you were looking at positions after your residency, what drew you to like the managed care kind of realm? So
I guess as a background, I decided to do my PGY2 in geriatrics because I wanted to stay broad. I wanted to do a specialization. I wanted that additional year of training because I feel like it would open more doors for me, but I also didn't want to get pigeonholed into one specific thing. And I felt like geriatrics was a really good opportunity to get that additional training and knowledge without being, compartmentalized into one small thing. Like there's solid organ transplant or there's cardiology. Like those are very ultra specific specialties. Whereas geriatrics is much more broad. And in my opinion, I mean, especially now when I work for a primary care organization that has babies all the way to your 95-year-old patients. So I see the whole spectrum. And the thing is a lot of the things that I learned in geriatrics is completely applicable to younger patients. And I'll always hold firm that if we treated all our patients like they were a geriatric patient, we'd probably be better off, and patients would just be on better therapy and better care earlier in life, and we wouldn't have as many problems, down the road. But what drew me to this position is kind of all the things that I had explained. Is probably the biggest population we have is Medicare patients. So that's kind of nice. It's right in my wheelhouse. That's something that I'm very familiar with, especially with my training in geriatrics. But as I mentioned, it's a new experience too, because I work with pediatrics. I do adult medicine as well. And then just the variability of the everyday tasks. And also kind of the allure of, maybe for some people, it's kind of nice joining a team with other pharmacists. But for me, I kind of thought it was a cool opportunity being the only pharmacy representation in our local organization. Obviously, as a national organization, we have plenty of pharmacists, but locally in Connecticut, I'm the only pharmacist. So it's kind of cool and scary all at the same time, but it allows me to make it what I want it to be and to really have a larger say in moving our organization forward than maybe I would have if I was just, you know, another cog in the wheel, so to speak, in a different place. So that was definitely some of the draws.
Definitely.
Plus, you know, it never hurts having a job.
Yeah. Oh yeah. No, definitely. It seems really cool that you get to, you know, have so many different aspects of it. You know, it's not just running insurance, running prior auths. You're doing, you know, you're doing medication use evaluations all the time. You're always looking at costs, and you're doing clinical research to be able to figure out, you know, what's the end, you know, line and what's the cost savings. But at the same time, I mean, you're optimizing patient care.
Yep, exactly. Yeah, it's like, I see what you did there. Yeah, I mean, it's kind of interesting because like some of the things that I do are definitely like a one-to-one, where it's like it's direct patient care, whether it's physically talking to the patient or just affecting an individual's care on their level. But a lot of the things that I do are population based. So it's kind of cool in that sense too, where it's like, you know, I have a couple examples of different things that happen to particular patients. And that's like, hey, you know, a light bulb goes off. Like, these probably aren't the only people in our population that are having this particular issue. And it's like, well, what can we do to prevent that for our entire population? So it's kind of cool where you can leverage the knowledge that you get and experiences that you get even in real time. And I could say for us, you know, like, we identified that bleeding was one thing that was happening based on individual chart reviews. And now we have 2 different programs in place to reduce the risk of bleeding for our entire population. So it's kind of cool. And you get to watch, you know, all of these things get put into place from, you know, the very infancy stages to the end. And you really get to see it through, which is super cool. And, you know, I'll be a nerd until I die. So I find it extremely interesting.
Yeah.
And it's nice.
Yeah, I feel like it's definitely nice being able to, you know, being able to see it all the way through. Because a lot of the times with my, you know, limited experience in hospital situations where we're doing research, I mean, you can retrospectively review a patient's chart, and you can see, you know, were they on that primary prevention coming in, but you won't really see, you know, the before and after. Whereas with insurance, you know, if you're one-on-one with the patient, that's amazing. And then also being able to, you know, fully see the refunds and everything, and be able to physically see, you know, when they started these medications and, you know, the savings over time and the quality.
Yeah, for sure. Yeah, it's where you know, for me, I think the really important thing is that, and you may not hear this all the time in managed care, but like, I would much rather make sure that we're providing quality care, even if it's, you know, maybe not as financially viable for the organization. And I think that that's important, you know, like sometimes the financial affordability aspect of things and the quality care meet, but sometimes they don't. Sometimes they oppose one another. But the most important thing is just, you know, I get to be that advocate for the patient, where I'm like, hey, you know what, like, I think that this is what we need to do, because that's how we do right by this particular patient. And you know, you make up for the affordability standpoint of it elsewhere when you identify other issues or trends in the population and try to optimize care to prevent those hospital admissions and things like that. And I mean, when you think about it, no patient wants to be admitted to the hospital. No patient wants to go to the ER. Everybody wants to be healthy and well and enjoy their life. So, you know, how I look at it is any intervention we can do for patients that improve their quality of life is a complete win, because we want them to be happy and healthy and live an awesome life.
Definitely. Seems like an awesome position. So how long have you been there?
I started in September of 2019.
Cool. And
so I've been there just over a year.
Have you said, like, is your role ever growing kind of thing? Have you noticed that you've started like taking on additional tasks and like new tasks and going in different directions than you originally thought you were going to go in this?
Absolutely. So, I mean, when I first started, my particular position was vacant for 1 full year. So the whole organization went without a pharmacist for a year. So it took a minute. You know, when I first started, I was focusing a lot more on quality metrics and star ratings and gaps in care, which, like, you know, is necessary, but, you know, ultimately kind of boring. You know, for me, it was kind of boring. So as I got more accustomed to the organization and understood, you know, what the needs are, where does my skill set fit in? And then it's like, you know, like pretty much with all things, especially when you're working with doctors, is it just takes one. It takes one intervention or one interaction where you really impress them and you show them that you know something and that you could actually be a benefit to them and the team. And once that happens, then you get inundated. Like I could definitely tell you, you know, from day one to today, you know, I was getting flooded with drug information questions through consults. I was working on 2 of our other affordability strategies. You know, I was doing patient reviews, root cause analyses as to like why this patient's getting admitted. What can we do from the case management side to prevent them from getting admitted again? Like, is there any medication optimization available to this particular individual? And, you know, like I said, like, definitely has expanded exponentially since I started. And it seems like the trajectory is just continuing to expand. And I think probably the next step is just, you know, when it comes to expanding, that's where you really have to start showing what your return on investment is. So that's kind of the next part, is showing that me or a pharmacist being part of the team saves X amount of money or increases quality of care by X amount. So once I'm able to kind of produce those types of numbers, then I think everything else kind of follows, but right behind it with, you know, expanding out the team, and hopefully, you know, 5-year plan is hopefully being the director of pharmacy at OptumCare Network of Connecticut. But, you know, we'll see. I don't want to, not counting my chickens before they hatch, but, you know, working every day towards that type of goal.
Definitely. And if you had one piece of advice for incoming students, or, you know, students who are looking to pursue managed care, what would your piece of advice be?
So for incoming students, my advice to you would be follow where your gut tells you. And I know that that's, you know, super cliche, and I'm sure a lot of people say that. But I think what it boils down to, and it's the same for when you're picking the college you want to go to, when you're ranking your residency programs, if that's what you want to do, if you're deciding between 2 different jobs, like, you really have to follow your gut. You really have to follow your heart, because I think deep down, everyone kind of knows what they want. And if you don't know, you really need to ask yourself those questions. Like, you know, is this the place where I want to be? Do I see myself here? Like, make a pros and cons list. Like really, really think about it. Don't just do something because your parents told you to, or your friend told you to. Like, you really have to make some individual decisions and make sure that you want to be there, because I think if you want to be somewhere, you're going to just have such a better experience than you would otherwise, and be so much more successful. And then in terms of managed care specifically, I mean, I didn't do a managed care residency. I mean, I did a residency in clinical, and I did inpatient and outpatient medicine and collaborative practice agreements, you know, the whole 9, like patient clinics, like very much direct patient care. So if you asked me then if I would have been in a managed care position afterwards, I would have been like, no chance. But I think that's because at the time I just had a misunderstanding of what exactly a managed care position was and can be. I think that there's definitely some managed care positions that maybe are more like cold calling patients and doing gaps in care and doing some of the things that I'm not as interested in personally. But within managed care, and I know this from sitting on national meetings with pharmacists from all over the country that work for Optum, is pharmacists can do a lot of cool stuff. And it doesn't, and like the more people realize that, the more our type of services are going to expand, and the more that the United States moves from like a fee-for-service world to a value-based care model where it matters more about the quality of care we're providing versus the quantity of care we're providing. Pharmacists are going to become even exponentially more important, and our roles and responsibilities are going to increase, you know, to the moon, in my opinion. So, you know, where I'm at now, I'm doing a lot of cool stuff, but there's so much more I can be doing, and hoping to get like collaborative practice agreements in place so that I could order labs and prescribe medications and do all kinds of different stuff that would increase, you know, my ability to do things and overcome some of the constraints and barriers that currently exist. But that's what I would say is don't count out managed care just because maybe you think maybe you're not into the numbers or the pharmacoeconomic piece of it. Like, it very much can be a clinical position. And I think, at least my understanding of where pharmacy is going, I think that it's going to be even more clinical by the time the person watching this video graduates than it already is.